Thank you.
Stephanie Watkins, on behalf of the Association of California Life and Health Insurance Companies, would like to thank the chair and staff and the author on the most recent amendments. We're currently in the process of reviewing those as well. We are currently still opposed to the bill, and I'd really like to highlight my colleagues' comments about we do support transparency, we do value our large employer groups. That was one of the reasons why we negotiated and worked with them on SB 1182 last year. We think it's most appropriate to allow that process to factor out so that large employers can get additional information, see what is affecting their rates, and they can make decisions that way. We think this bill is a bit premature, so for those reasons, we're opposed.
Thank you. Anyone else in opposition? State your name and position, please.
Mr. Chairman and members, Teresa Stark with Kaiser Permanente. Also want to echo our appreciation of the chair and the staff for, and the author for the removal, and the sponsor, for the removal of the prior approval language. That is certainly an improvement to the bill. With a quick look at the language, we do remain concerned about the remaining provisions of the bill, and unfortunately will remain opposed at this time, but hope to continue to have conversations. Thank you.
Tanya Robinson Taylor on behalf of the California Hospital Association. We are on record with an opposed position. We will need some time to review the amendments. Thank you.
Maureen Higgins on behalf of America's Health Insurance Plans. We also remain opposed.
Dan Chick with HealthNet, also in opposed.
Allison Barnett with Anthem Blue Cross, also opposed.
Good afternoon, Andrew Kiefer with Blue Shield of California, and we're still in opposition. Thank you.
Kevin Pedrati representing Aetna, opposed.
Got distracted earlier, I'm sorry. Stephanie Roberson on behalf of the California Nurses Association, in full support. Thank you.
Thank you. Comments, questions, Senator Roth?
Thank you, Mr. Chair. Apparently, we just got the amendments too. I apologize. Neither I nor my staff have really had an opportunity to take a look at them, so I may have to stay off this bill today. But I'm curious. My understanding of it is it merely requires, if you hit a trigger, that rates and the basis for the rates be submitted. Is that correct? Without really anything further.
They would be subject to rate review, and if they hit a certain threshold, they could be deemed unreasonable by the regulator. It's my understanding. I mean, again, the bill is just being amended today, so there would be a regulatory action associated with that filing. It's not merely pure transparency.
I would like that clarified, because I thought it was simply the way it's been changed. It was simply a rate submission with the basis for the rate structure also submitted, so those who were interested, probably smarter than I am, could take a look at them and figure out whether they looked high or low or something acceptable. Could somebody clarify that for me?
Mr. Chair. I'm impressed. Maybe Ms. Capel would like to.
You are
clarify.
right, Senator, but Ms. Capel can explain further.
Today, in the individual and small employer market, the two regulators do review rates for products and then do make a determination as to whether they're reasonable or unreasonable. They cannot, however, deny them or modify them. The insurer and the health plan are able to move forward with unreasonable rate increases. Senator Leno referred to a number of instances in which they thought better of it and did not move forward with unreasonable rate increases, but there is, with the bill as amended, there is nothing to prevent a health plan from imposing an unreasonable rate except the public shame and the negotiating ability of a large purchaser to say they don't wish to have an unreasonable rate. Thank you.
Of course, what's reasonable for one person is unreasonable for another, and maybe there's a difference of opinion. How difficult is it to submit the rates and the underlying basis for the rates as called out by this bill?
So, we don't have a cost estimate for this particular bill, but rate review bills for large group in the past have triggered Department of Finance opposition due to the state cost associated. I don't have a dollar figure associated with this particular bill yet, but because this triggers individual filings, we would expect at least the cost to be high.
On the companies?
Yeah, yes, we do expect it to be expensive for the companies. Again, we are just reviewing the amendments, but it would require the hiring of new staff, actuaries, and other types of staff in order to prepare what we think will be volumes and volumes of individual filings. Again, per my testimony, the large employer market is highly customized. There are thousands of different policies. Some employers actually have different policies agreed to even with the same health plan. So a health plan may have a contract with a large employer for various products within their company. So it's highly complicated and customized business.
Well, does this bill call for the submission of the backup data in a particular form? I mean, presumably, a health plan has certain reasons for setting the rates that it sets, and if you have those reasons and they're documented in some form, could you not simply submit that rationale with the rates that you've set, and wouldn't that satisfy the requirement in this bill without the need to hire legions of actuaries and develop additional backup data? Is that a fair question?
It's a fair question, Senator. Again, we're going to have to review the amendments. If the factors, we believe the factors are conflict with what might be currently cataloged by the health plan.
Mr. Chair, if I may respond to Senator Roth's question. Senator Roth, you were right. One would hope they already have the actuaries on their staff before they raise their rates above the average of all their other rates of the plans, which is the trigger. And keep in mind, there is a trigger. You don't raise above your average, there's no review. It's only when increases are extraordinarily high relative to their own average increases that we believe the review can contain costs, because, of course, they prefer not to be reviewed. And as we've seen, this is not conjecture anymore, we all took a leap of faith in the passage of our bill in 2010 in review for the individual and small group markets. And within the first 2 years, the insurance commissioner opined that over $300 million had been saved by consumers, and now it's over $500 million. So just the fact of having to be transparent and public only in the case of extraordinary high increases, we know this can contain costs, and so that's the purpose of it.
Thank you, Mr. Chair. I believe Senator Pan had a question. Is that correct?
Thank you so very much. And actually, Senator Leno, I want to thank you for bringing this bill forward and for taking the amendments as well, and also your efforts at transparency, not only in this bill, but in the past. I think certainly we heard the stories from people talked about, they see this large increase in their premium and they don't understand why. And certainly, yes, large groups have negotiating power. At the same time, to me, it's not just a negotiation for what the rate is for that one particular agreement. It's also what can I try to do with the members of my, whether it's my union, if it's a union plan, or with my whatever, actually business even, and what I can try to do to get those, that I might do with my own employees or members to get those rates down. I think that's an important thing, that tool that we need to give the purchasers to be able to do that. But I did just want to ask a question about a couple points brought up by the opposition, just to clarify.
Sure.
So one is that they talked about how the plans in large groups are highly customized, and so how does that factor into trying to do the aggregate piece in terms of trying to get. And then the other one is, we do have the medical loss ratio laws, and so how are we providing within those constructs? I mean, I didn't hear anyone talking about, well, what we think is they're shifting all the money necessarily into marketing and but how does that? That's been brought up, but I think that, well, I'm interested in your answer about within that, how does this information going to help the purchaser, who's trying to buy the plan in terms of their own efforts to try to control costs? So,
Of course, the more that the purchasers know, they can take action and communicate with their own members to address those specific concerns. But if they're in the dark, they don't know where to turn to attend to preventive care or particular illnesses or disease. they are literally in the dark. So the more information helps them improve the health of their workers, as well as for them systemically to be able to contain their costs.
So this really is about, it's what's going on, even that 85% that goes to the medical.
Right, so if it were by chance emergency room visits made us have to skyrocket, well, then you're going to attend, why are our members going to emergency rooms so often? Just an example.
And then I don't know if you want to try to tackle the specialized nature of large group plans or.
In terms of the aggregate reporting, it's by each carrier, and it reflects the factors that go into establishing the rate. There is some degree of customization, but in talking with the trust funds that I represent, more of it is like the customization when you go to buy a car and you have different option packages, especially when you're some thousands of employees. It's sort of the off-the-shelf options package. This year it's wellness incentives, next year it's some other way to control costs. And so it's not as if I can say, I'd like a purple van with polka-dotted interiors. They just don't come that way. Thank you.
Any other comments, questions from
Very brief close.
any of the members? In a minute. Well, no one's even moved the bill yet.
Okay.
So you can't close unless somebody moves the bill. So is there a motion? Oh, Senator Wolk moves the bill. I have a couple comments I'd like to make.
Of course, go right ahead.
And then you can do your
Yes,
close.
Mr. Chair. You get to make a couple comments.
So, no questions, just a couple comments and maybe a few concerns. This bill, the way it's presented, and I apologize for some of the members getting it in a mock-up form within the last 45 minutes, but it was a fairly extensive, fairly large bill. And in its initial form, I was opposed, and I wasn't prepared to vote on it. I made it very, very clear. I didn't call any of the members. My biggest concern was the prior approval, of course, the rate reg portion, especially in light of what happened with the proposition, what's happened in previous times, and the positions I've taken. I still believe that the market needs to play its natural course out, and if we're really going to have the conversation on rate reg, then we need to bring everybody in. We need to bring hospitals, providers, pharmaceutical, et cetera. But I don't know if this was the place where we're going to have that conversation. This bill has been scaled back significantly, even with some of the concerns that we've had or I've had, and, with regard to some of the triggers from Cover California, CalPERS, requests by the purchaser, where now it's only the average, or the rate increase is greater than the average rate increase as determined in Section 1385. And of course, that the trigger, the one that I was concerned about most, was the trigger with regard to the excise tax, which obviously affects a lot of the large purchasers. I do have a few concerns, obviously, with the highly customization. I understand that the medical loss ratio is a big part of it, but I'm confident in the amendments that you're taking, that I'm prepared to support the bill. But it has changed significantly since when we first seen it. If the members don't feel comfortable voting on it because it came late, but we do have it in mock-up form, and we have taken a pretty serious look at it. So I will be recommending a support bill, and with that, Senator Leno, please feel free to, at this time, make your close.
You're very gracious, Mr. Chair. Thank you. Let me commit to the committee that, and to those who have spoken in opposition, my door is open. We do want to be inclusive. There's no other way that we do our business. Many of the concerns that we heard were the same kinds of concerns that we heard with our bill for the individual and small group market in 2010. What we didn't hear from the opposition is why rates continue to go up 10%, 20%, 28%, at a time when, as our president said in his State of the Union address in January, healthcare costs are going up at the slowest rate of growth in the past 50 years. Something's going on. We're not suggesting something nefarious. It's just that we don't know. And that's the purpose of the bill. I'd ask for your aye vote.
Thank you very much. We have item number 12, SB 546, due pass as amended to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Aye. Mitchell, aye. Monning. Nielsen. Nielsen, no. Pan. Aye. Pan, aye. Roth. Wolk. Wolk, aye.
currently has 4. We're going to place that bill on call.
Thank you very much, Mr. Chair and committee members.
I believe we are now with the members that will be presenting bills. We're going to move, let me make sure. Yeah, we're going to move to item number 3, SB 145, Senator Pan, Health Facilities Patient Transporting.
Okay. Put that olive oil in that grist.
All right. Good afternoon, Senator. Please proceed.
Thank you. Thank you, Chair and members. First, I would like to thank the Chair and the committee staff for working closely with my office on amendments to the bill. And in order to delay referral to the next committee, I'm committed to taking the amendments in the Judiciary Committee. SB 145 prohibits a hospital from transporting a patient who is deemed medically unstable due to severe intoxication to another location, except when the patient is stabilized or appropriately transferred to another licensed health facility by laying out stricter penalties than those currently in law. There's been substantial evidence that revealed that Prime Healthcare Services was transferring patients who were admitted to the emergency room for acute alcohol poisoning to police departments, correction facilities, and county jails by calling 911. Despite being one of the largest hospital chains in the state, Prime had an unusually high number of cases where the police were called on patients in the emergency room, in fact, as much as 6-fold compared to some other hospitals. For example, during the first 3 months of 2014, 124 emergency calls came from the Shasta Regional Medical Center, which is a Prime hospital. This averages to about 41 calls a month. Another Prime hospital, Desert Valley Hospital, had 509 emergency calls in the first 6 months of 2014, averaging about 60 calls per month. In comparison, Dignity Health Hospital, Mercy Medical Center, which is located only 2 miles away from Shasta Medical Center, had only 53 emergency calls in the first 9 months of 2014. What has been documented at Prime hospitals highlights a hole in the current law when it comes to preventing hospitals from dangerously transferring patients in an attempt to save money. SB 145 is intended to stop and prevent this practice that poses a risk to patient safety. I respectfully ask for an aye vote, and I have witnesses in support. Thank you.
Thank you. Anyone to speak in support? State your name.
Good afternoon, Mr. Chair and members. Pat Whalen, Ellison Wilson Advocacy here on behalf of United Nurses Association of California, Union of Healthcare Professionals, a proud member of ASME. Really want to thank the author for bringing this bill and thank him for working with all the stakeholders on the amendments. We think it's removed some opposition and it's made it a better bill. For UNAC, this is really a matter of patient safety. We hope this bill will discourage the rather despicable practice of patient dumping and taking advantage of intoxicated patients who can't take care of themselves. So we urge your support.
Thank you. Anyone else?
Yeah, I'm David Miller. I'm the research director from SEIU UHW. I'm here to speak in behalf of the bill, in favor of the bill for the 145,000 healthcare workers that we represent. I wanted to thank you, the committee and the author, for the opportunity to speak. We believe this bill discouraged patient dumping by placing financial penalties on hospitals that have severely intoxicated patients arrested rather than treating them. We have found some hospital systems, in particular health system, Prime Healthcare routinely calls 911. In particular, Prime Healthcare has non-combative patients with potentially lethal levels of alcohol poisoning taken to jail. Some of these facilities call 911 or the police twice a day seeking patients to be taken into custody. For example, one facility, Desert Valley in Victorville, called 911 726 times a year from 2010 to 2014. That's 3,326 calls during that period. Prime Shasta Medical Center called almost 7 times the amount of a neighboring hospital to 911. We think the state has a compelling interest in stopping this practice and protecting patients. We're afraid that this may spread beyond Prime. The patients who this bill protects are medically unstable and put in peril when put into police custody for transfer. Currently, patients with blood alcohol levels of 0.4 and even higher are at risk of dying or being put into police cruisers and dumped into the criminal justice system. This legislation will ensure that all patients are stabilized before being discharged and that the criminal justice system is not relied on a way to get rid of undesirable patients.
Thank you. Anyone else in support?
Michelle Cabrera on behalf of SEIU California in support.
Hi, Amy Durbin with California Medical Association. Want to thank the author and sponsors for working with us on addressing our concerns with the bill, removing our opposition, and with the amendments, we'll be moving to a support position. Thank you.
Thank you.
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. Previously, we had been opposed to the bill. With the amendment being taken, we are removing our opposition. We just want to take the time to thank the author, his staff, the sponsors, and the committee staff as well on working through this issue with us.
Thank you. Opposition?
Good afternoon, Mr. Chair and members. Connie Delgado with the California Hospital Association, here in opposition for two main reasons. This bill is unnecessary because we already have EMTALA. This bill just puts into place what is existing law, but with additional penalties for violation. And we would like to note that only a physician can make the authorization to transfer a patient. Yet under this bill, there will be additional penalties placed on hospitals. And for those reasons, we are opposed.
Mr. Chair, member Stephanie Roberson on behalf of the California Nurses Association, also regretfully in opposition. Obviously, we do oppose and have opposed the whole issue of patient dumping. So we do agree with the senator on remedying that issue, but we align our comments also with the Hospital Association in that there are sufficient protections in law that curb that practice. We also challenge the data that we read in the fact sheets on this bill. We looked at the discharge data in various counties, Shasta in particular, and looking at Sacramento County and the statewide averages. And Shasta is actually among some of the lowest with respect to discharge data and encounters. Sacramento County is at 40%, and the statewide total average is at about 39%. Shasta County is at 0.22. So again, we do not believe that any of these county statistics are suggestive of either statewide EMTALA violations or a systematic problem with patient dumping of unstable patients with alcohol poisoning. We believe the legislation is in search of a problem, not resolving any real problem in the current law. And some of the highlight of the statistics from counties are only with one hospital, yet we do not believe the statistics are evidence of improper handling of inebriated patients in hospital emergency rooms. We do understand that there's some language around current workplace violence regulations that are going into place. We did think that there is an unintended consequence in the bill that would potentially curb hospital workers from availing themselves of the use of calling 911 in the event that a patient was violent. We need to take a little bit closer look at the language to see if that remedies our issue on that, but we're still opposed. Thank you.
Thank you. Anyone else in opposition? Questions, comments from any of the members? Senator Roth?
I'm just trying to get some clarity here. If this bill prohibits hospitals from causing a patient, et cetera, to be transported to another location except when the patient is medically stabilized, how does the bill hurt? How does it cause harm to the hospitals?
Well, there are existing penalties that CDPH has that are for under the EMTALA regulations, under those guidelines. This bill would create a separate scheme with additional penalties for that are higher than the current. So essentially, it's the current law plus an additional higher penalty.
I see.
And I'm sorry, without evidence that there's an issue that needs to be addressed, in our opinion.
I see. So in order to qualify for to be entitled to receive the penalty, the hospital would have to transfer someone who is not medically stabilized.
with the physician, with the appropriate authorization from the physician. A hospital doesn't make the authorization for that
No,
transfer.
I understand.
Right.
In other words, a physician would be transferring a patient who is not medically stabilized.
And we simply don't have evidence that that is actually occurring, but yes, that would be the case.
Thank you, Mr. Chair.
Thank you. And seeing no other questions or comments, is there a motion? Moved by Senator Monning. Would you like to close?
I respectfully ask for an aye vote. Thank you.
Thank you. We are item number 3, SB 145, due pass to judiciary. Chair's recommending a support. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, no. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk.
That currently has 5. We're going to place that bill on call. Why don't you just stay there? We'll go ahead and do item number 11, and then we'll do item number 14. Item number 11, SB 435, medical home healthcare delivery model. Please proceed.
Okay, thank you again, Chair members. I present to you SB 435, which requires the Secretary of the California Health and Human Services Department to convene a working group to identify appropriate payment methods to align incentives in support of patient-centered medical homes. The patient-centered medical home is known to be a successful model of delivering services. Patient-centered medical home model will be able to address increasing costs, shortages of primary care professionals, and meet the demand for services for those with chronic diseases and mental health disorders. This type of model establishes a partnership between the patients' families, and healthcare providers so that patients receive the right care at the right time. No one should have to navigate this complex health system alone, and the patient-centered medical home ensure that no one will. Patient in the medical home, there's been numerous studies that have shown success in both reducing utilization and improving quality of care. In fact, I myself have personally had the opportunity to visit a patient-centered medical home model in Fresno, California. Actually, the Fresno Unified School District, they worked with their school employees and were able to demonstrate better quality and improve cost savings. So SB 435 will establish a group that will make sure that the best patient-centered medical home model is created for California. This bill has no opposition. I respectfully ask for an aye vote.
Thank you. Anyone like to speak in support?
Yes, thank you. My name is Dr. Carla Kakatani. I'm a past president of the California Academy of Family Physicians, and we're sponsors of this bill. To this point, we've focused a lot on coverage and access, but now it's time to move our energies on to focusing on the improvement of the actual delivery of healthcare. And PCMH, or patient-centered medical home, is a well-studied and growing concept to do this. Unfortunately, California is behind a lot of other states in moving ahead with this model. Other states have had success breaking down the barriers between payers, providers, purchasers by playing the role of a convener to get folks to the table and provide some antitrust protection so we can have this conversation and build this. Building a PCMH and a team to help patients manage proactively their chronic illnesses takes a lot of time and effort, and in fact, it's been compared to building an airplane while you're flying it. So naturally, physicians have been reluctant to take on this kind of change without the assurance that more of our, or most of our payers are going to incentivize it and measure its success in a similar way. We want to build something comprehensive that we know that our Medi-Cal patients, our Medicare patients, our United Healthcare patients, our Blue Shield patients, all will be able to take advantage of, because we don't want to treat people, different people from different payers in a different way. So this bill could play a key leadership role in breaking the barriers to delivery reform by having Health and Human Services play the convener role and give all the players in this a push. The end result could be a system that works better for both patients and their care teams, so we can get the right care to the right patient at the right time and in the right setting, which, as you know, doesn't always happen right now.
Anyone else in support?
Yeah, Chair Member Sean South on behalf of the California Primary Care Association. We want to thank Dr. Pan for his continuous work on this topic, and we're proud to support this bill.
Good afternoon. Bill Barcelona, CAP Chief Physician Groups, in support.
Thank you. Anyone else in support? Opposition? Questions, comments?
I'll be glad to move the item. Good luck.
Motion to move the bill by
Long
Senator
overdue, and it's been very long.
Senator Mitchell had a question?
Yeah, just a clarifying question.
clarifying question. Legislation that became statute in 2013 directed the Department of Healthcare Services to establish a California Health Home program in the Medi-Cal program. So how is this work group different? Is it because you're looking at programs outside of Medi-Cal?
So this does look outside Medi-Cal, and I appreciate your leadership, Senator Mitchell, in working on getting Medi-Cal to move in this direction. So
This is everybody else?
This is everybody else, yes. Thank you.
Thank you.
Okay, we have a motion. Would you like to close?
I respectfully ask for an aye vote. Thank you.
Thank you. This is item number 11, SB 435, due past appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Aye. Mitchell, aye. Monning. Aye. Monning, aye. Nielsen. Nielsen, no. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk. Wolk, aye.
Currently at 6, we're going to place that bill on call. We're going to go to your last item. Sure. Item number 14, SB 610, Medi-Cal Federally Qualified Health Centers and Rural Health Clinics Managed Care Contracts. Please proceed.
Thank you, Chair Hernandez and members. First of all, I'd like to thank the Chair and the committee for working with my office, and I'm accepting the committee's suggested amendment. SB 610 requires the Department of Healthcare Services to finalize a new reimbursement rate and complete annual reconciliations for federally qualified health centers, FQHCs or rural health centers, within specified timelines. Currently, there are no timelines that requires DHCS to finalize reimbursement rates or annual reconciliations for FQHCs or rural health centers. This has resulted in DHCS taking approximately 5 years to finalize a new rate and approximately 3 years to finalize reconciliation. Meanwhile, while waiting for a new rate to be finalized, clinics have to continue seeing patients, but are only being reimbursed for about 80% of what they're owed. The 80% reimbursement, combined with the tight operating margin, forced many clinics to take out loans so they can continue providing services to the patients they need. Furthermore, the 3-year delay in finalizing the reconciliations has resulted in the state owing nearly $50 million to clinics, most of whom are folks.
Thank you. We have a motion to move the bill. We do have support on both sides, and I believe there's no opposition. Please proceed.
Okay, clinic's ability to provide quality care is being jeopardized, and I have witnesses who I'll ask to be very brief, since it seems like we have considerable support. Thank you.
Yeah, Chair Member Sean Southwell on behalf of the California Primary Care Association support, and I have with myself Kevin Mattson, who's the CEO of the health center.
Kevin Mattson's President and CEO of San Ysidro Health Center. We serve about 90,000 patients in South San Diego County, and I can only echo what Senator Pond said about the monies owed and how much we would appreciate getting paid more timely.
Thank you.
Ginger Smith with the California Primary Care Association, and I'm just here to answer any technical questions and ask for your support.
Andy Patterson, California Primary Care Association. Vote for your aye. Thanks.
Thank you.
Amber King with the Association of California Healthcare Districts, also in support.
Bill Barcelona with the CAPCHI physician groups in support.
Lucinda Bazil, Deputy Director of Lifelong Medical Care in the Bay Area, in support.
David Lee, CEO of Tiburcio Vasquez Health Center in the Bay Area, in support.
Jody Hicks with the California Academy of Family Physicians, in support.
Thank you. Opposition? Questions, comments? Seeing none, we have a motion by Senator Wolk. Seeing no questions or comments, would you like to close?
Respectfully ask for an aye vote. Thank you.
Thank you. Item number 14, SB 610, due passes amended appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Aye. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk. Wolk, aye.